I hope I'm audible. So we'll wait for 5 more minutes, and if few more people are joining, we'll start in next 5 minutes. I'm audible, right? Thank you. So let's wait for another 5 minutes. So in general, if you can, anyone can give the feedback for the quiz. How was it? It was too tough, too easy, too complicated? Anyone wants to give any feedback? So after all, so people tend to think infections are simple, and there is no need of a separate ID because all the specialties manage their own. So do you know all the infectious diseases? Do you know? So obviously it is difficult. So yeah, that was my aim, to make people think. So that's why it was not a typical MCQs or anything. I just wanted to bring forward, most of them are the common scenarios which we face. Anyone would like to give feedback about the quiz? Results are all ready, but again, it has to be typed in the Word format, and so I will try to release it by today evening. So please give me some time. If not today evening, definitely by tomorrow morning. So there were overall, I need to check how many teams register. I mean, we had 90 plus teams registering, over which we had participation from around 69 teams. So yeah, it will take time to make that list. And I have also not seen the entire results as of now. So okay, then let's get started. So how well do you know your infectious disease? So again, this opportunity I would like to use to invite all of you to the IDCon 2023. This is our annual infectious diseases conference in Jodhpur. So we had one last year. So this year it is on May 6th. So first question, a 22-year, okay. Again, I would just like to confirm, am I audible Is my slides visible? Is my slides visible?
Also, and the slides are visible.
Okay, thank you. So let's get started. So first question was a 22-year-old woman presented in India with 2 hypopigmented skin lesion and 14 weeks 14-week history of weakness of her left hand. On examination, there is a thick and tender ulnar nerve and anesthesia where within her skin lesion. So definitely all the features are typical of leprosy. So what is the treatment of leprosy? That is as simple as that. What will you give in this patient? So as we all know, leprosy treatment has been simplified before, like we have the same posibacillary and multibacillary, but the treatment regimen has become the same for both. And I mean, there is some discrepancy between DHS's WHO, but in general, it is the same treatment, which will be 6 months for the posibacillary, and multibacillary will become up to 12 months. And just like TB, there are certain indications for steroid. That was the only catch point here. So steroid is indicated in patients with so that there is improved chances of neurological recovery as well as reduction in the inflammation. So yeah, so I had tried to divide the topics, like I wanted to cover the lesser discussed topics, so which include your tropical infections, your viral infections, HIV, and OIs. And in more on rather than the OIs, I was covering the non-infectious complications of HIV, including the lymphomas. Then I had important sick case scenarios which we come across in day-to-day life as an ID. Then I had one on transplant associated infections as well as parasitology. So these were the neglected infectious diseases, I can say. So that is what I tried to concentrate. And those of you who had attended Aspicon quiz will be familiar. In that, I have covered most common antibiotics and the other related topics in that. Next question, a 45-year-old woman from Bihar in North India presented with a long history of fever, weight loss, heaviness in the abdomen. That was obviously massive splenomegaly, and there was pallid. Laboratory examination showed anemia and hyperglobulinemia. So all these clinical features, there is fever, weight loss from Bihar, and there is massive splenomegaly. All these go in favor of your leishmaniasis. So which vector? So it is asking the vector for the leishmaniasis. So again, as we all know, the vector for leishmaniasis is nothing but the sandfly. But again, there are species, that is phlebotomine and leukemia. And in general, leukemia is in the Americas and phlebotomus is a species which is the old world. So your the answer for this was phlebotomus. And your fly is the vector of your human African trypanosomiasis. Anopheles are the vectors of malaria, as we all know, and similium are the vectors of onchocerciasis. Next question, a 49-year-old homeless patient attends the emergency department complaining of itching and fever. He describes the onset of fever approximately 7 days ago. On examination, he has widespread rash and excoriation marks. So what is the most likely vector for this illness? So the clinical features are very evident. There's itching, fever, and this one. So this is suggestive of your epidemic typhus. So it's a louse bone. So basically it is a louse bone. So that is what is causing all the symptoms. And the causative agent is your Rickettsia prowazekii. And it is the body louse, that is Pediculus humanus. So that is the answer for this question. next question, 54-year male presents with flitting rash and eosinophilia 8 weeks after returning from tropics. Which of the infection require an intermediate snail force? So the question is very evident. The first part, again, it's plus minus. So if you just read the second part of the question, so which of the following requires intermediate snail host? So that is the question. So if all of you will be familiar with the amongst the options. If you see, the snail host is only there in schistosomiasis. So Dipholobothrium, the intermediate host is copepod, that is a freshwater crustacean. Paragonimus, the intermediate host is a crab. Echinococcus, the intermediate host is a sheep. Strongyloides, that doesn't require any, it doesn't have an intermediate host. And even for cystosoma, the intermediate host is a snail. Again, the further, if anyone wants to go one step ahead, so the important, they have different species as well for depending upon the species of the cystosoma. Mansoni is by the species of snail, that is by Homphalaria. Hematobium and intercalatum by Bullina species. Japonicum is by Oncomelania species, and Mekongi, Schistosoma mekongi, is by Tricula species. Next question. So this question, I think I've got the maximum wrong answers. So obviously, I'm trying to misguide you by putting unnecessary details in this. A 48-year-old rice farmer from Northeast Thailand presents with a 7-day history of fever, headache, painful urination. She has diet-controlled diabetes mellitus. On examination, her temperature was 38, pulse was 142, BP was low, she was having hypotension. So all these features are suggestive that she could be in sepsis. She had reduced consciousness and was tender. There was tenderness over the renal angle. Urine analysis. So this is the clue. Urine analysis was positive for leukocytes and nitrates. So what is the most likely positive organism? So if at all the rice farmer, it was unnecessary history which I have added just to confuse you. So this typical, all the features point towards going towards the patient is in urosepsis with query pyelonephritis. So, and the organism is nitrate reducer. So the most common organism which we are seeing is E. coli. Klebsiella and Proteus are there, but it is less common. Proteus is not nitrate. Proteus is quite rare, and that too, if the patient has any device-associated infection, then it can be likely. Melioidosis can cause septicemia, but rarely affects the urinary system. Burkholderia is an environmental organism that is Thailandensis, and this causes seldom disease in the humans. Next question. A 22-year-old man was admitted with 3 days of high fever, arthralgia, and an erythematous rash 24 hours after returning to UK following a 3-week tour to Thailand, Laos, Vietnam, Cambodia, so Southeast Asia. Then the blood count reveals there's mild thrombocytopenia, but RFT and LFT were normal. He was given IV ceftriaxone. Malaria films were negative. On day 4, his temperature has settled and a definitive diagnosis was made based on the PCR from the peripheral blood taken on admission. So this is where I have tried to misguide. So PCR. So which of the viruses will require PCR for diagnosis? Dengue, obviously, as we know, we have the facility of it can be done by any ICT as well. But PCR also can be done in early, like if the 1 to 3 days, the diagnosis is by the PCR. He was discharged without further treatment and made full recovery. So all the features, so can fever, arthralgia, erythematous rash. Erythematous rash is one thing which is a little, and mild thrombocytopenia, which is little against your enteric fever. Influenza, again, there is no history of any other cough or anything. Then leptospirosis, LFT, RFT is normal. Epstein-Barr virus, usually it is, even if it is there, the patient will not have, will have erythematous rash after antibiotic, or there is no history of any sore throat. So in this, putting towards the risk factors, it is Thailand travel and the history, dengue fever is the correct answer. A 66-year-old nun developed non-bloody diarrhea, which was self-limiting with bowel motions returning to normal. 2 weeks following this episode, she developed swollen, painful knee and presented to the local emergency department. The orthopedic department has done joint aspiration which was sterile. Inflammatory markers, including CRP, was raised, and the serum testing for HLA-B27 was positive. So, which of the pathogen is least likely to cause this condition? So, the key is least likely. So, what are we dealing with? So, this we are looking at the triad of reactive arthritis, which is Rito syndrome causing reactive arthritis, urethritis, as well as conjunctivitis. And usually, though it affects men, the common organisms can be all anything like Shigella, Salmonella, Yersinia, Campylobacter, amoeba, chlamydia, but Giardia is usually not associated with it. So usually the patients will have oligo or monoarthritis, usually involving the lower extremities. Next, a 28-year-old male presents to the genitourinary medicine clinic with urethral discharge and dysuria. He was screened for STI and was found to be VDRL negative but TPHA positive. So what is the most likely explanation? So to understand this, we need to understand what is VDRL test and what is TPHA test. As we all know, VDRL is a non-treponemal test, whereas TPHA is a proper treponemal test. In India, what we follow is a reverse algorithm where we do the non-treponemal test first, followed by a treponemal test. So in the outside India, they follow the reverse order. That is, they do a proper treponemal test first, followed by a non-treponemal test. So one more important thing you need to remember is your non-treponemal test will become negative after the patient is treated, whereas your treponemal test will remain positive for a long duration of time, and you cannot use it for to look for the response of the treatment. So, if the patient is detected to be VDRL positive, then you will, the next step will be to look for TPHA. So, if it is positive, we are determining the patient is having syphilis. And depending upon the type of lesion, you can, if the patient has the chancre, etc., then the primary syphilis. If the patient is having the gamma, etc., you go for the tertiary syphilis. So based on the type of this one, you can classify it into primary, secondary, and tertiary syphilis. But if at all I am giving a scenario where the VDRL is negative, but TPHA is positive, that means the patient has had the infection. And because VDRL has turned negative, so this could be because the patient has been treated for syphilis before. Next question. A 29-year-old female presents in 33rd week of gestation with a fever of 1 day after having several episodes of diarrhea. Which organism is particularly dangerous? Particularly dangerous, having a potential to cause of this presentation. So all of these can cause diarrhea. Like Salmonella, Listeria, Giardia, Tinea, etc. But the important thing is she is pregnant. So what are the which organism amongst these will have an implication on the fetus as well? So if you look at it, so Listeria monocytogenes is the common organism which can give this similar presentation, as well as there is high risk of if the patient has contracted this infection while in the early pregnancy, there is risk of miscarriage, and the neonate is born to these mothers can develop neonatal sepsis and meningitis, and other options like NTS can also cause severe maternal disease like chorioamnionitis, etc. But these infections are less likely than the Listeria. Next, I think this also had got very mixed answers. So let's read the complete question first. A 7-year-old female was treated for relapsed ALL with methotrexate, cytarabine, and cyclophosphamide. Chemotherapy was given by central line, Hickman line. That is, she came to us with neutropenic fever. There is no localizing signs or symptoms. She was commenced on piptaz and vancomycin, which is usual protocol for febrile neutropenia, which led to resolution of the fever. 72 hours later, her blood cultures flagged positive, and the gram stain showed fungal hyphae without chlamydiospores. She was commenced on liposomal amphotericin but remained febrile for after 7 days post admission. Her fever settled only after removal of central venous catheter and change of antifungal therapy to the voriconazole. So, which is the most likely organism. So, when you look at fungal hyphae are there, without chlamydophores are there. So fungal hyphae are there. So which one is almost ruled out? You can tell. Or is almost ruled out, which usually you will be seeing as yeast cells. Next, Malassezia furfur again will have that fungal hyphae with some yeast-like cells, which so that also again is ruled out in this condition. Then your leftover options include your Fusarium, Pecilomyces, as well as Aspergillus fumigatus. So even your fusarium, there will be the proper curve-shaped chlamydospores which can be seen. And in Aspergillus fumigatus, again the typical the typical form of the Aspergillus, that's fungal hyphae, can be seen. So, and also the central line associated infections are common, like Aspergillus associated central line infections are very rare. So in these patients, the common species include your Pecilomyces fusarium and Pecilomyces Lalicinus and Verote are the two species, and fungemia has been reported, and especially if the patient is having hematological malignancy and indwelling prostatic material. So next question, a 31-year-old woman delivers a female child on second centile, which at now the child is 8 months of age and is found to have PDA, that is patent ductus arteriosus, as well as early bilateral cataracts. The pediatric team suspects congenitally acquired rubella. Which laboratory test may help you in making the diagnosis? So we are suspecting congenital rubella syndrome, and the child is now 8 months of age, and there is some PDA and bilateral cataracts. So when we are looking at the diagnosis of congenital rubella syndrome, the time of the diagnosis will make a difference what laboratory test you are going to send. So congenital rubella syndrome can cause cardiac, usually seen as PDA, cerebral and ophthalmic, like cataracts and auditory or that is sensory neural defects. There can be prematurity, low birth weight, neonatal thrombocytopenia, etc. So if the child is less than 6 months, rubella IgM in the cord blood or the serum sample taken in infancy can be used. So if it is, as we all know, the IgM is not transferred, but if you detect IgG at the time when maternal antibodies should have disappeared, that is, they usually disappears by 6 months. So rubella IgG, if you're detecting still in a baby, which is now that baby is 8 months, that means the patient has had the congenital rubella syndrome. So other thing obviously you can look for is the PCR for rubella. Next question. During a ward round on the neonatal unit, the team discusses a baby who had failed initial hearing test. During the pregnancy, the mother described she had a flu-like illness with fever and fatigue, but did not seek medical attention. She has a 3-year-old daughter who is not potty trained yet and wears nappies. On examination, the baby has evidence of hepatomegaly confirmed on ultrasound, and there is no other signs of CNS dysfunction. MRI is brain is normal. HB is normal. Platelet, ALT, bilirubin is slightly raised. Saliva sample CMV PCR is positive. Maternal IgM and IgG is positive for CMV with low avidity. What would be your recommendation? So this, what are we dealing with here? We are dealing with a congenital CMV. Looks like we are looking at for some congenital CMV infection. So in this, the maternal IgM, IgG is positive. And what is the avidity? So since CMV, the IgM can persist for long. So like that of your toxoplasma. So we'll have to look at something called the avidity. So low avidity means it is So if the low avidity means recent infection, whereas high avidity means it is a remote infection. So and the saliva PCMV PCR is positive. So first thing you need to understand how will you make the fetal diagnosis. Then after the diagnosis, what is the treatment of choice? So for fetal diagnosis, it can be the antenatal amniotic fluid PCR or the postnatal PCR of saliva or urine can be done. This saliva sample should be taken 1 hour after the feeding to avoid the maternal contamination. And usually the patients will, the babies will present with unilateral bilateral hearing loss. So this patient had, this baby had saliva CMV PCR positive, and also the history shows that the mother has acquired the infection recently. So this all points towards congenital CMV infection, and this requires treatment. The treatment depends on whether the patient is the child is mild or asymptomatic, or if the patient has moderate to severe infection. And this how are you going to differentiate? Is mild means just having isolated sensory neural hearing loss, whereas moderate to severe includes having thrombocytopenia, petechiae, hepatomegaly, splenomegaly. So our patient had hepatomegaly as well as some amount of thrombocytopenia for the age of the baby. So that comes under the moderate to severe category criteria, which has to be treated. And the treatment is oral valg acyclovir for 6 months. Next, a 55-year-old HIV positive Kenyan male presented with weakness and numbness of left arm and leg. He was diagnosed HIV 5 years previously and has struggled with adherence. His last CD4 was 60, and on examination, he has hemiparesis of the left side with hemisensory loss. MRI shows a focal mass lesion in the right hemisphere. What is most likely to cause this presentation? So all these features are resembling that there is some mass. The patient is HIV with low CD4 count and having a mass lesion. So if the patient didn't have any mass lesion and is just having this progressive weakness, we could have thought of PMLE, that is progressive multifocal leukoencephalopathy. Primary CNS lymphoma is also higher in cards, but if at all you're looking at the infection, so any mass-like lesion with a low CD4 count, toxoplasma is the one which comes into mind. So toxoplasma abscesses are most common and worldwide when compared to others. So toxoplasma is the answer for that. So next question, a 35-year-old HIV positive male presents with fever, weight loss, and decreased appetite. On examination, he has widespread lymphadenopathy. CT of the chest and abdomen is as shown. So you can see there is quite significant hepatomegaly and multiple nodes are there. And then plasma HIV, his CD4 is 114 and plasma HIV viral load is 65,000. HHV8. So what is HHV8? Is another one EBV. So EBV viral load is 10,000. Lymph node biopsy shows the typical onion skin appearance on HPE with interfollicular plasma blasts expressing latent HHV, that is EBV nuclear antigen. So the clue is first thing is the widespread lymphadenopathy, weight loss. All these point towards some malignancy, that is which is HHV8 is positive, so it is an EBV associated malignancy. Then the take home point here, the onion skin appearance is typical of your multicentric Castleman's disease. So we can have two types, localized or multicentric forms, and usually it affects young adults, and you can see the usual presentation is in form of masses in the mediastinum or the neck. And the treatment part, rituximab can be done, can be considered, and chemotherapy can be added for the aggressive disease. Next question, a 51-year-old male who is HIV positive attends clinic for review. He has been on antiretroviral for 6 months, now has undetectable viral load. CD4 count is also very good, 615. However, he has spent long period of therapy, but with a high viral load. when he was younger. So before he current situation is he's having undetectable and very good CD4, but before that he when he was younger he had a high viral load. What end organ disease does HIV virus directly cause? So the first part of the question it's like just to confuse. So second part is the important thing. So the HIV and opportunistic infection are two different things. So there are certain things which the HIV directly will cause the damage. Then there is HIV with the OIs causing the damage. So among the end organ disease, which is exactly caused by HIV, one of it is HIV associated nephropathy. That is HIVAN. It is a form of focal segmental glomerulosclerosis, and along with that, what else can be the other direct effect of the HIV is your hand, that is HIV associated neurocognitive disorders, including your AIDS dementia complex. So others like enteritis and retinitis are usually caused by opportunistic infection rather than the HIV virus itself. And hepatitis can be due to various reasons, including HIV enteropathy, as hepatitis B or C co-infection, or as a result of ART itself. Next question. A 20-year-old male was admitted with PUO and splenomegaly. On evaluation, he was found to have an oscillating intracardiac mass attached to his aortic valve. He has no known heart disease. His blood cultures grew Streptococcus gallolyticus in 3 out of 4 blood culture bottles. Which of the following is true? So Streptococcus gallolyticus. So does it belong to which group does it belong to? So it belongs to group D streptococci and not the viridans group. The viridans groups consist of your mites, oralis, etc. And gallolyticus. So when anyone asks like in infective endocarditis and there is streptococcus gallolyticus, or then nowadays we are getting evidence with enterococcus with no unknown focus also. Colonoscopy is warranted because these are usually the bacteria which are resident or which are commensals of the GI tract, and whenever there is a malignancy, so because of which there is a breach in the GI, and that is why these organisms are now coming into the bloodstream. So colonoscopy is warranted to look for any malignancy which is always done in whenever the blood culture is showing Streptococcus gallolyticus. And HIV has no role, and treatment of choice of Streptococcus gallolyticus. So Streptococcus are in general susceptible to your penicillin, so that will be your treatment of choice. A 38-year-old male presents with acute onset fever, headache, and confusion. On examination, there is no neck stiffness and no focal neurological defect. MMSE is 21 out of 30. MRI is as shown. So you can see the lesions in the temporal. So there is some lesions in the temporal lobe. And LP is performed, and his CSF results are WBC 16 red cells are there. WBCs are 16, red cells, or the RBCs are 450, protein is 280, and glucose is 48. So the clues are your temporal lobe involvement, your RBCs, presence of RBCs, and not all the RBCs in the CSF is due to the puncture because of wrong collection. Plasma glucose is 51. Microscopy shows no organism. So what is the most appropriate next investigation? So with all this, it is more towards acute onset and no neck stiffness. This is going towards your encephalitis. So it could be the most common which causes temporal lobe involvement with this picture shown is your viral meningoencephalitis, especially your HSV. So the diagnosis is not the serology, but the CSF PCR is diagnostic. So again, the CSF PCR has to be done early and not later, because later it can be negative. Next, blood culture from 7-year-old male with hematological malignancies grows GPC. gram-positive cocci. Initial laboratory investigation show the organism is catalase positive, coagulase negative, and resistant to antibiotic teicoplanin. Which of the following is most likely? So I had put this question for the uh, microbiologists who are participating. So again, and also as an ID person, we are not aware about the very a few important intricacies between the cons. So this is catalase positive. So obviously, all of these, so it can be any of the staph or cons. The important thing is coagulase is negative and resistant to antibiotic teicoplanin. So this I also got to know when I was just making this question, that your hemolyticus has higher resistance rate and is in general resistant to your uh, antibiotics, glycopeptide antibiotic like teicoplanin. And important other cons which you need to remember is your like staph aureus will have positive slide coagulase test, whereas it will give negative tube coagulase, and staph intermediates will have positive slide coagulase and weak positive staph latex as well. Next, an 18-year-old female presents with headache, neck stiffness, and a peripheral rash. So, which is as shown below. So, headache, fever, the headache, neck stiffness, so meningitis. So with this rash is nothing but purpura fulminans. So this is suspected case of your Neisseria meningitis. Which member of the staff is most likely to be offered prophylaxis for this condition? So whenever you are looking at a patient with meningitis and we are asking a question on prophylaxis, so which are the two important organisms where prophylaxis is given? One is your Neisseria meningitis and another is your H influenza. We usually don't see these cases in India, but in general, these two are the important, apart from your streptococcus pneumonia, these two are the other important causes of meningitis. This is especially important in situations like now the Ramadan is going on and there will be increased Mecca preliminary range, and there is increased risk for these infection. So we need to understand how it is transmitted to know whom should you give the prophylaxis. Neisseria meningitis is a gram-negative cocci and usually present in the oropharynx, and transmission is by kissing or transfer of saliva or through a large particle droplet infection spread from nose or mouth. So what are the situations here we have seen? Receptionist talking for 5 minutes, triage nurse who take history for 10 minutes, staff nurse who took observation for five times each of 5 minutes, medical doctor who took history and examined for 20 minutes, anesthetic who intubated for 5 minutes. So just exposure to the eyes or respiratory droplets is not an indication for prophylaxis. And the procedures which increase the contact or the spread of this is whenever it involves close contact, like that of the anesthetic trying to intubate. So the most transmission can occur. So that person amongst the first preference is for the given offered prophylaxis is the anesthetics. Next question. A 36-year-old male presents with non-painful erythema of the leg. So this is nothing but erythema nodosum. He otherwise has no other symptoms. The lesions are not hot and there is no lymphadenopathy. CRP is slightly raised, ESR is raised. Which is the most common organism associated? So whenever one talks about erythema nodosum lesions, so the most common cause is Streptococcus pyogenes. It's not that others can't cause, was the most common. So other infective causes which can be causing erythema nodosum include the Mycoplasma, Chlamydia, Yersinia, Mycobacterium. Staph in general is lesser known cause of your ENL, erythema nodosum. Next, this I put it because just I wanted to create an awareness that all lymph nodes or the cervical lymph node lymphadenopathy which you're seeing is not TB. A 35-year-old female of Iranian origin presents with 4-month history of fever, weight loss, and night sweats. Yeah, TB. So an annular blanching rash, affected the upper torso. She also has an annular blanching rash. On examination, there was a single enlarged lymph node in the cervical region. CT showed a single necrotic lymph node, which was excised and shows features, that is, large infiltration of histiocytes and necrosis. So whenever you are seeing this picture, so otherwise all these patients, irrespective, in India, the patient will be put on ATT for long. Her symptoms settled and she remains well. What is the most likely cause of the underlying illness? So all of these Kikuchi's, toxoplasma, lymphoma, tuberculosis, sarcoidosis can cause cervical lymph nodes. Along with the symptoms, if you're correlating, TB and lymphoma are high on cards. Toxoplasma can present, but usually it is asymptomatic. Sarcoidosis is a diagnosis of exclusion. But when you're seeing this typical histological appearance of necrotic and histiocytic infiltration, Kikuchi's disease is the one which you need to think about. So Fujimoto disease is a rare benign and self-limiting illness. So there is fever and predominantly cervical lymphadenopathy, and it is thought to affect predominantly young adult females, and it's a self-limiting condition and may take few months to resolve. Next one, a very long question, I agree, but I really wanted to put this forward. Again, this is most of the situation. This will be diagnosed as TB and put on ATT. A 30-year-old male presents with fever, weight loss, and mild abdominal pain. He was a cameraman for a documentary channel and has extensive travel history, including Central America, North America, Northern Africa, Central Asia. There is no past medical history, no drug usage, but some amount of alcohol he consumes. He is not in a current relationship. On examination, there is no remarkable features except pyrexia. His abdomen is soft. And chest X-ray, no abnormalities. CT of the abdomen revealed bilateral adrenal mass, which was biopsied. So IGRA is negative. Our HPE shows granulomatous inflammation with histiocytes, and TB-CB NAT is negative. ZN stain is negative. So what is the diagnosis for this granulomatous disease? So whenever one thinks about granulomatous disease and which is causing bilateral adrenal mass, the top two differentials which comes to our mind is your TB first, and then your which should come to your mind is your histoplasma. So histoplasma, so infectious causes of adrenal insufficiency. So these masses can cause adrenal insufficiency and the patient can present with that. So bacterial, we have MTB, which is high on cards, Neisseria meningitidis, MAC, etc. Fungi, histoplasma. But if you are comparing between all these species, TB is the first, then we look at the, and the thing which causes granulomatous infection resembling TB, next DD should be your histoplasma. Next one, a 29-year-old female with no past medical history and no other cause of immunocompromise has come with seizure. HIV test is negative. CT shows this as shown. So this shows multiple abscesses which you're seeing. So which organism is least likely to cause this cerebral abscess? So all of it can cause staph, strepto, peptostreptococcus, anaerobes, nocardia, actino, except your Neisseria meningitidis. Next, 71-year-old female develops SSI following total hip replacement. She subsequently develops pain in the joint but has no fever, and her inflammatory markers are normal. During subsequent debridement and washout, there is no visible pus, but 5 samples are taken out for microbiological examination. Which of the following is most likely to confirm the PJI? So PJI, the prosthetic joint infection, the definition or the diagnosis according to the EBJIS current definition, that is 2021, is, so they have classified as infection unlikely, likely, and infection confirmed. Any positive finding will have infection. So if at all you're seeing a sinus tract, if the synovial leukocyte count is more than 3,000 with predominant neutrophilic, that is 80%, Positive lateral flow immunoassay for the alpha defensin. This is one new addition. They have added the biomarker in synovial fluid. And microbiology, more than or equal to 2 positive samples with the same microorganism, or showing the load of organism more than 50 CFU of any organism. Histology demonstrating more than 5 neutrophils in more than 5 high power field and presence of any visible organism. So these are the criteria for confirming the diagnosis of PJI. Others all will come under infection likely if there is 2 of the positive findings, like CRP more than 10, leukocyte in the synovial fluid more than 1500, single positive blood culture, single positive intra fluid culture, and evidence of loosening, previous poor wound healing, recent fever or bacteremia, purulence around the prosthesis, etc. So when you look at this one, so obviously it's not more than 3. Only one sample Cutibacterium, no, at least minimum 2 or more than 2. CRP more than 50 will come under infection likely but not confirmed. So I've asked for confirmed. So MRSA in one sample, no, but Staphylococcus epidermidis, though it is a cons. So if you're seeing in 3 out of 5 samples, this you will have to consider as a pathogen, and and confirm this confirms the PJI. Next question: a 23-year-old female presents with fever, neck pain, and persistent sore throat for the past 1 week. On arrival, she is hypotensive, tachycardic, and febrile. So fever, neck pain, sore throat, hypotensive. So she's in sepsis. On examination, mild swelling in the left side of the neck and erythema in the posterior aspect of the pharynx. So not all the swellings in the neck are lymph nodes. And chest radiographs demonstrate opacification of the left lower zone. And an aspirate of the neck swelling has a gram stain has been sent. Which of the following is the most likely causative organism? So when you look at the clinical picture, so fever, neck pain, and some swelling, and the patient is in sepsis. There is some erythema in the posterior part of the pharynx. So all these are suggestive of your Lemierre syndrome. So the causative organism for Lemierre syndrome usually is a polymicrobial infection. One of it is which is your Fusobacterium necrophorum. So it is a causative agent of Lemierre's disease, and the bacteria usually colonizes the infection site and then spreads through the parapharyngeal space, invades the peritonsillar blood vessels where they can spread to the internal jugular vein, causing the thrombus and subsequent embolization. And it can spread frequently to the lungs, causing cavitating and effusions. It is a gram-negative anaerobe. So most often we don't send anaerobic culture. So this is one of the important place where the anaerobes has an role. So that is why Lemierre syndrome, the treatment of choice is your PIPTAS, and there is no use of adding clindamycin. So if you are using you can use PIPTAS because most often they are producing, along with the there is other flora of the mouth which can produce your beta-lactamases. So this was the last question, I think. A 25-year-old female has 20-week antenatal scan which demonstrate microcephaly. She had received full UK childhood immunization schedule. There is no history of rash, ulcers, adenopathy, or fever during the pregnancy. Blood test. So you can see CMV, IgG positive. So CMV is again one of the ubiquitous virus. So IgG positive is not surprising. So more than 80 or 90% of individuals would have contracted the disease in the childhood, and IgG will be positive. CMV PCR, again, why they have not done, it has been done, but no significance. Rubella IgG is positive. So yeah, childhood immunization, rubella is given. So the IgG has to be positive. Toxo IgG is positive and toxo IgM is positive. TPHA and RPR both are negative. So IgM positive, again toxo IgM, it can persist for a long time, but in this scenario, there is microcephaly as well. So all these are in favor of your Toxoplasma gondii infection. that is your congenital toxoplasma infection, which includes microcephaly. Other viruses which can torch panel, which can cause this, includes your CMV, tox, herpes, Zika, etc. And usually the highest risk when acquired in the first trimester. Pregnant women usually will not have symptoms. Some can have this flu-like illness with some lymph nodes, posterior cervical group of lymph nodes. IgG, as I mentioned, IgM persists for long. And again, just like CMV, we'll have to look at the avidity, which differentiates. So low avidity means recent acquisition. High avidity means past acquisition. So thank you. That was about the discussion of the various MCQs. I hope. Let's see the chat section. Okay. So are there any other doubts? I hope I have made it somewhat clear. Again, few points maybe we some may disagree, but the decision of the quiz master is final. So again, I'll be telling, I'll be releasing the results as soon as possible today, by today evening, if not maximum by tomorrow. So again, the top 15 teams I'll be putting up the list of rank for all the participants. Then among them, top 15 will be invited. In case anyone from top 15 is not ready to come here for the final round, so the other subsequent participants, I'll be is invited for participating in the IDCon. Again, it's not necessary that you have to be a part of the quiz team to participate. IDCon is open for all. I hope to see all of you here. Thank you. And if there are no further questions, maybe we can end it here. Okay. Thank you. And again, all of you will be having my number. So any doubts, you can just leave